Well, good evening, everyone. Welcome to our AO continuing series of our hand surgery essentials. For those of you who have been with us from the beginning of this segment, starting in September and running through mid-November, welcome back. For those of you just joining us new tonight, our talk tonight is going to be on metacarpal fractures, and you can see the next few talks running through mid-November. The majority of our time tonight, Nick Poulos will be giving a real nice presentation on metacarpal fractures. Myself and Tom Hunt will be chiming in, and then we're very lucky to have Becky Naduski join us, a therapist from Elon University, who's going to give some perspective from her end on what she looks for and some of the important nuances in terms of rehab. By way of disclosure, these are all of our disclosures, and they've all been addressed, nothing that impacts this evening's talk. For those of you interested in CME credits, upon completion, a link will be sent to you and answer the series of questions in that evaluation, and then you'll be given a link to obtain the credit. Just a word on Zoom etiquette. Your microphones have all been muted and the video's turned off. There is a Q&A function, and we welcome questions during the talk. I'll be sort of taking a look at those, myself and Tom Hunt. Where appropriate, we'll ask Nick and maybe interrupt Nick to address a salient point. And then some of them we can address more directly depending on the nature of it. But the QA function, there is a chat function, but that won't be working as well as the QA for us tonight.
All right, well, thank you, Dr. Lawton. This is a real honor for me. I remember my first AO basic course. My wife was 39 and a half weeks pregnant, and she told me, sure, just go, it'll be fine. And it wasn't fine. And I had the privilege of attending one of the AO Advanced Hand courses with Dr. Lawton and Dr. Hunt. And I would encourage all of you to seek that out once normal times resume. It's hard to get a good cadaver course these days, and AO does an outstanding job with that course. So I hope it comes back, and when it does, I hope you all take advantage of that. Tonight, we're going to be talking about metacarpal fractures. Last week, we had a great talk by Dr. Wu on phalangeal fractures. So you're getting a double dose of Penn Med here. But the goals of today, at the end of this session, what I'd like to make sure everyone's able to do is describe the deforming forces that act on metacarpal fractures, identify physical exam radiographic signs which indicate the need for surgical fixation, and really appreciate the balance between the need for mobilization for fracture healing and early motion for long-term results. And one thing that's great about this course as well is that we have a therapist here every single week with us, which you don't often get with many orthopedic courses. We're going to start here, and I want everyone to kind of put this into their mind here. So this is a 22-year-old soldier who fell while conducting an exercise. And you can see here he has a third metacarpal shaft fracture, sort of oblique spiral in nature. Just think about this, have this in your head as we go through thinking about the deforming forces, what indications would lead you towards surgery or not surgery, and how you would treat it surgically or non-surgically, and when you would get them started with motion. This is really down in the deep cuts, if you will, the Aot classification. We often use this for research purposes, of course, and distal radius is, the 23s. But for phalangeal fracture, or for metacarpal fractures, we don't see this very often. But just so you know that it exists, the metacarpal bones are 77. You pick your metacarpal. The shaft is a 2, like many other long bones, and then your type of fracture. So for this spiral shaft fracture, like we just saw of the third metacarpal, it would be a 77.3.2a. The reason I put this on here also is to highlight really what I'm not going to talk about tonight. Dr. Gaston has a great talk next week on articular fractures. So he, I suspect, will be talking about the 77x 3s and 1s. I can't imagine you would ever get tested on that. But to just highlight or quickly go over those metacarpal base fractures, they're often associated with dislocations, as you see here. Of course, these are often operative. And then the head fractures, the distal fractures, these are intra-articular fractures. They need to be well reduced and often require surgery. So that's what we're not going to talk about. So what are we going to talk about? We're going to talk about metacarpal fractures. And we're going to start by talking about the anatomy and the deforming forces. And then we'll go through the non-operative and operative treatments for them. So it really starts for me with the osteology. So the CMC joints of the second and third digits, the index and long, those are fixed, rigid joints. They don't have a whole lot of motion. And that's really in contrast to the more mobile fourth and fifth CMC joints. And this is important as we talk about later what we can accept in terms of angulation and what's an acceptable amount of deformity in the metacarpal. And then of course the thumb has that saddle joint, which I wasn't able to recreate with PowerPoint without stealing that GIF. So I appreciate whoever put that on. Going distally to the MCP joints, here it's much more similar across the four. They're condyloid joints. So when the MCPs are in extension, there's quite a bit of freedom for radial and ulnar deviation of the digit itself. The collateral ligaments here are lax. And this is in contrast to when you flex down the MCP joints and the collateral ligaments become taut, and you have much more stability and much less radial and ulnar deviation. Just as a point, thinking about and relating this to other things we think about in orthopedic surgery, right? When you see that person who comes in with that intracapsular hip fracture, they're shortened and externally rotated. And part of what they're doing is maximizing their joint capsule for comfort. And the same thing happens with metacarpal fractures and fractures in the hand, which is to say, if in the absence of treatment and proper splinting, the joint space is maximized in extension. And so the MCPs will tend to rest in extension, and that then leads to IP joint flexion through the flexor tendons. So that's why it's important to kind of treat these early and get these in the right spot, because left to their own devices, the hand will adopt this posture that's not conducive to rehab later on. And then also the volar plate here, which resists hyperextension. And they're connected between the metacarpals through these intermetacarpal ligaments. And this provides quite a bit of stability here in terms of length. So while you might see a comminuted metacarpal shaft fracture, we don't see a whole lot of shortening, though if you see several millimeters of shortening, that might be an indication for fixation. So that's a little bit more about the static forces that are acting. But what are the deforming forces here? So when we look at the thumb, there's the thumb abductors, the opponents, and then the adductor, which is unique because it originates from the third metacarpal. So there's this odd connection between the third metacarpal and the thumb to be aware of. Your wrist flexors, which insert proximally on the second and fifth digit, the FCR and FCU, and the wrist extensors, which insert on the second, third, and fifth. Remember, ECRB inserts on the long finger, so it's sort of a good reverse mnemonic for depending on where you are in your training. Those kind of things can be helpful. The digital flexors, which run in the carpal tunnel, right, 9 tendons, because it includes the FPL. And here they run out the FDPs to the distal phalanx, the FDSs to the proximal, or to the middle phalanx. So all causing flexion forces. And when we see this in profile, again, in red are the digital flexors causing that flexion moment. In green are the extrinsic extensors. So that would be your EDC, your EIP, your EDM. And then the intrinsic muscles, which create a flexion force at the MCP, but an extension force at the IP joints. And so when you sum up all of these deforming forces, what you end up often seeing is this apex dorsal angulation with a variable amount of shortening because of the intermetacarpal ligaments and other connections to the surrounding bones. So thinking about the different fractures that we see, we should have some idea of what's underneath them when we're looking at the x-ray. So why does the x-ray look the way that it does? And one way to think about metacarpal shaft fractures is really to break them up into 4 different types. There's your subcapital fracture, the transverse fractures, the oblique, and the multifragmentary fractures. And we'll spend some time looking at each of these. And one of the things that's great about talking about metacarpal fractures is that it's most like the long bone, probably of any of the bones in the hand. And so really all of your AO principles really apply here. And we'll see a use of plating and lag screws and intramedullary devices that are similar to other long bones that you have. So for the orthopedic surgeons, it's a good way to review all of your basic sort of fracture AO techniques. And for all the plastic surgeons, it's also a good review of all the things that the orthopedic surgeons are learning at AO Basic and AO Advanced. There's some obvious operative indications. Of course, an open fracture, there's certainly debate about when that might need to go to the operating room, but something like this, and this is the likely an exit wound into the hand. Clearly, this needs some sort of treatment. Multiple metacarpal fractures, and part of that is because we said that the stability of the metacarpal is often splinted by the adjacent metacarpal. So if you have 2 in a row or 3, you're really losing a lot of length stability. Rotational malalignment. So I credit for Dr. Lawton for sharing this photo with me. When I show this to my 7-year-old who was born during AO Basic, for him, he looks and sees the pinky finger and thinks that's rotated incorrectly. So this highlights the real importance of examining the other side because people do have some rotation in their digits, especially in the small finger and sometimes in the index finger. So take a look at the other side when you're comparing. That small finger is normal. What's off is the ring finger, and you could see how if this patient makes a fist, that's not going to work out so well for them. And if you don't believe me, Dr. Lawton's initials are right here. So that's just to confirm that that I'm right, I hope. And then unacceptable displacement. Here you see a comminuted fracture of the fifth. So what does that mean? Well, again, it means different things depending on what joint you're talking about or what bone you're talking about. The index and the long, they have fixed CMC joints. They can tolerate less angulation than your small and ring fingers. And just because these numbers are out there and they've been out there for a long time, these have to do with function. So patients might not cosmetically be happy with this deformity, but you might be able to reassure them that they should have pretty good function as long as they're within these limits. Again, rotational deformity, we really can't accept a whole lot because 1 degree of rotational malalignment in the metacarpal could be 5 degrees by the time you get to the fingertips. So it really amplifies by the time you get to the end. So let's sort of take these each one at a time and highlight sort of the AO principles that they use to fix them and also sort of unique features of them. So here is 3 views of a subcapital 5th metacarpal fracture. This is that typical amateur boxer fracture, the person who got drunk, who punched the wall, hopefully a wall. So you see this, and when you're using that displacement, you can see the displacement looks a lot worse on that oblique picture in the middle than it does on the lateral. So those angulations that I provided or that you look up or that you see in the books, those really have to do with on the lateral projection. So don't use your oblique because that might exaggerate it. And this is the JAWS maneuver, right, for reduction, for closed reduction of these. And what you're doing is you're really applying those anatomic principles that are anatomic features that we talked about, because by flexing down the MCP joint, what you are doing is tightening those collateral ligaments. So you have much more control over the distal aspect of the metacarpal here. And then you give that counterforce into the metacarpal head to allow you to reduce that fracture. And you can use this not just for subcapital fractures, but certainly other fractures of the metacarpal shaft. So this is good to have in your armamentarium. The issue becomes, what do you do with them next? And so for all of you who have done the JAWS maneuver and then put your patient into what you think is an intrinsic plus splint, what you end up finding is that you've actually just flexed them right back through the fracture. And I found that extremely frustrating as a resident. And so when I finally found this paper, and I must have been a PGY4 because I didn't get to the Journal of Hand Surgery early enough, I guess. Here's a paper by one of my partners, Alex Shin, and one of my friends, Dr. Hoffmeister, and mentors, who, thank goodness, they randomized people to extension of the MCP versus flexion. And once I found this paper, I was golden because I started putting these patients in MCP flexion. Got to make sure they can still flex their IPs, but at least I could maintain my reduction for some period of time. And hopefully at some point we can get our therapist to chime in about whether or not what the results she see are consistent with what they saw, which was really no difference between the two. There's a lot of ways that you can fix these. Retrograde K wires work really, really well. You'll also see a lot of antegrade wires, especially on the 5th metacarpal. I know my partner, Dr. Rizzo, who was on the call last night, he does a lot of antegrade pinning, I think, bouquet pinning. For me, this lends itself really well to an intramedullary screw. I think that it fills the canal well, and it helps to maintain your reduction. You do, as you see in that picture in the upper right, have to go into the joint itself. I think that Dr. Lon probably has a picture of this later on. Hopefully not too much load through that part of the articular surface and that you get some fiber cartilage over that screw, but you really have to bury that screw head in there. Important anatomic thing to know is that the fourth metacarpal is narrower than the fifth. So when you're thinking of doing this, it's worth knowing sort of the anatomy of the widths of the metacarpals. Here's metacarpal shaft fractures for the transverse version. So you see this here in 3 views. Again, more angulation with the oblique than you might see in the other 2 views. So you can still use that JAWS maneuver to help you reduce the fracture. And then the next step is how do you hold that reduction? And there are a variety of different splints for metacarpal fractures that you can use, whether you use that volar slab in an intrinsic plus, like you see at the top. Again, it's hard not to bend them through the fracture there. And then these other techniques where you have multiple layers of plaster, a dorsal and a volar with buddy taping in this area, or in the last one, a short arm cast with an aluminum splint outrigger. All different options to try and maintain the reduction that you've obtained in the emergency department or in the ED or clinic. So these fractures are often unstable and they're really slow to heal. So these lend themselves well to compression plating. And I would argue also in the metacarpal, because of the eccentric loading that we just talked about, there's probably some component of tension band plating here as well when you're doing this, because you have eccentric loading on that bone. But regardless, a compression plate here can do well. These do heal slowly, like I was saying. And the thing that's the beauty about compression plating is because you're getting primary bone healing, you're not even going to see the bone healing. So you just have to follow it clinically. And clinical healing will progress quicker than radiographic healing regardless. So this is kind of nice because then you don't feel so obligated to follow them radiographically. You still follow them, but you don't feel as beholden to the radiograph, I should say. It's more about the clinical picture. So transverse fractures, I think they lend themselves well to compression plating. When you're doing open reduction and internal fixation, it's just like anywhere else. This is really soft tissue management, and that's the key here. So you can make an incision. There's a variety of ways that you can do this. Might want to go between metacarpals if you have them. Often people try to avoid going right over the metacarpal. You're going to have to retract your extensor tendon or tendons, depending on where you are. And then you do a good fracture debridement, debride out the hematoma that's in there, get an anatomic reduction, and place your plate. And then the key is just like when you get a divot on the golf green, you got to leave it better than the way you found it, or at least as good as you found it. So get some periosteum over that plate so that the tendons can glide freely before you close them up. Moving on to the oblique fracture, like my patient that we showed at the beginning. Here again is 3 views of an oblique or a spiral fracture. They're really probably spiral fractures because you see them oblique in multiple planes, as you see here in this 3 views. So that rotation, it's almost like an inclined plane, right? It slides down that inclined plane. And if you think about fractures and characterized fractures based on whether they're reducible or not, these are usually reducible. The problem isn't reducing it. The problem is that it's hard to keep that stability. Here is that technique. You're going to require some rotation and some traction to undo the oblique fracture. But again, like an inclined plane, it often wants to spiral right back down to where it was before. These lend themselves really well to lag screw fixation. And I wish I had a great picture of 2 or 3. That would be awesome screws. But what you really need to set this situation up well is you need to have twice the length of your fracture. Your fracture, I should say, should be twice the length of the width of your metacarpal. And that really means that you can get 2 screws in there. And 2 screws is the magic number. I think 3, of course, is even better. You know, there's good data on distal fibula fractures, right? That 3 screws is as good as a plate. So 3 screws and at minimum 2 screws if you're going to do this. In this case here, I fixed it with a lag screw and a neutralization plate, which is yet another plating technique. So we've seen intramedullary fixation, compression plating, neutralization plating, and I said maybe tension band plating, all with metacarpal shaft fractures, which is really what's great about talking about them with you and teaching them. Finally, the multi-fragmentary fractures. So these are comminuted fractures by definition. That's multi-fragmentary. Here's one of the 5th digit. Often they're crushing injuries. They can be high energy. They can involve multiple metacarpals, and you really have to be aware of compartment syndrome. So when you get in to these fractures, you should be prepared to do compartment releases, and you might want to think about where your incisions are because those incisions between the 4th and 5th and 2nd and 3rd, those are utilitarian incisions for compartment releases to be able to release the interossei, volar, and dorsally. I think for these, you can lag what you can, but if they're really, really comminuted, then you go to the bridge plate, which is yet another of sort of the 5 different ways that you can use a plate in open reductions, internal fixations. So here's a bridge plating of that fracture. I was able to get one compression screw in there or one lag screw in there to make it a little simpler of a fracture. So going back to my patient, 22-year-old soldier who had fallen and suffered this injury, he was a little bit short and a little bit of malalignment, but not a ton. And I thought he would really do better with getting him fixed and some early motion. In fact, he really wanted to get back to the fight, so to speak. So I thought about this, and I actually went with retrograde K-wires for him. Where we were, I thought that was a useful technique for him. This is him at 4 weeks. So retrograde pinning, you want to go through that collateral recess so you don't bugger up the collaterals. You want to stay as much out of the joint as you can and allow them some range of motion. And then pull the pins at 4 weeks to really get them moving. And fortunately, he did well. Here you can even see callus formation, of course, because this is indirect bone healing. So you will see some callus formation. But most importantly, he wasn't tender. So I knew it was safe to pull the pins. Here he is. I think this is at 6 weeks. So again, good callus formation at this point. And then we have a video here of him shortly thereafter. So really pretty good range of motion for someone with a metacarpal fracture, suffered in theater, and now ready to go back to work. Oh, sorry. So my take-home messages from these metacarpal fractures, and again, I'm really enthusiastic about teaching them because I think that they really highlight a lot of AO principles, and they really emphasize the anatomy. So deforming forces create these predictable patterns of displacement. And whatever your non-operative treatment you choose, it must allow for some early motion. And I think Dr. Wu did a great job last week talking about that part of treating hand fractures. And lastly, the great part is that surgical fixation really depends on specific fracture patterns. There's not a one-size-fits-all for these, and it really allows you as the orthopedic surgeon to think critically about how best you're going to maintain your reduction and allow the patient to begin their range of motion. So thank you all, and I'm going to pass it back to Dr. Lawton to talk about some other cases.
Well, thanks, Nick. That was great. So Nick's given us all the tools to treat these fractures, and I thought it would be fun to run through some cases. So this first one, Nick, you said you wish you had one of these. So why don't you, so this is a 20-year-old college soccer player who fell and hurt their right hand. And why don't you tell people as you're looking at the x-rays sort of what you're thinking in terms of the implications of what the x-rays may have for his exam.
Yeah, so I think when you see this, and obviously we don't even have to really measure the shortening. So a couple of things that stick out. One, it's a border digit. So its ability to maintain its length is a little bit more difficult, and that might be more of a soft indication for fixation. So it's going to be hard to maintain this reduction with closed means. You can see how short he is, and when it's a spiral pattern, again, it's that inclined plane sort of thing. So I would be concerned about rotational malalignment as well.
Exactly, and he in fact does have a clinically rotated small finger. So as you mentioned, you want to look at their cascade and look at it in extension and flexion. So given the nature of this fracture, he's obviously a young, active person and wants to get back to that. So what are your thoughts? Yeah,
so the best thing from a soft tissue perspective, I think in my mind, is to try and do lag screws. It does fit that 2-to-1 ratio here. Again, minimum 2. I'd prefer to get 3 if I could. And I think no matter what system you're going to use to do this, you need to make sure that you understand and know their plating options, because you might get in there and it might be comminuted, or you might comminute it yourself when you put too big of a screw in, or you're too close to the tip of that fracture and you chip it off. So make sure you have a backup so that you could plate it but I would try going in to see if I could do lag screws.
Yep. So that's exactly what I thought. And I think you're going to have to control it, Nick. There we go. Okay. So you noted in your talk 2 times the cortical diameter, which this certainly had. So I was able to get 3 screws in it. And was it just a bad day in the OR? How come the screws don't look like they're all lined up nicely?
Well, I think, we call them oblique fractures, but they're really spirals. So you're just riding that spiral fracture around and staying perpendicular to the fracture line, I suspect, as best as you can.
Yeah, so exactly. So each one of these screws is perpendicular to the fracture at that point. So when I'm explaining these to patients, I use the analogy of like a paper towel roll, because everyone can sort of see that not only is it just the angle that you see, but it's also spiraling around that. And that way people can really understand. And then when they look at the x-ray, they don't think, you were, not attentive when you put in your screws, but that you're actually trying to do something with each one of those. And as Nick said, this is good, healthy bone, but, I could have easily fractured off that spike there, and having the ability to then plate that. So, if I planned on putting 2 or 3, but really only one of those screws was a good interfrag screw, then a neutralization plate would have been important.
Can you talk about the size of your screws, the size of the plate that you would use if you had to bail out to a plate?
Yeah, so excellent. So without being, specific to a brand, in a slight young lady, maybe something as small as a 1.5 screw or a 1.7 screw. But in a, big football player, maybe a 2.0 or a 2.3 screw, or the corresponding plates. So, it sort of depends on the size of what you're trying to do. And a lot of the plates and screw systems allow you to go between them, and mix and match.
Great.
So Becky, when do you want to see them to get them moving?
So I'm going to ask you first the question about how stable your fixation is and how you feel about it. I notice this is a 20-year-old and it's his dominant hand, and he's also an athlete. So I also want to know if he's in season or practicing, and that's going to help me understand how conservative or how progressive we can be. And so because it's a shaft fracture, and because if you felt like you had good fixation, I would probably want to put him in a nice approximation splint around his palm and buddy tape the ring and the small together for some good early motion. I would want to see him as soon as you'll let me. I would love within the first week to get him moving, because the fracture is far enough away from the joint. I feel like he could safely move the MP, PIP, and DIP. Nice splint to kind of hold that 5th metacarpal approximated up to the 4th and to the others, and the buddy tape to help keep the alignment. I also want him to start some good scar massage, depending on how much you had to open. We know that on the dorsal aspect of the hand, there's very little soft tissue under the skin. And so it's very easy for these scars to get adhered. And so it'd be really nice to start some scar massage early as well.
Excellent. So there was a couple questions relevant to this. So if you only use lag screw to fix the metacarpal shaft, you always use external support like a splint or cast, and how long? Sort of dovetailing into what Becky said, yeah, I will put them into a splint or a cast for 3 to 5 days after. Basically get some early incisional healing. And then, depending on what day of the week I do it, ideally get them into therapy within a few days and get them moving. As Becky sort of mentioned, depending on their play, if I need to protect them, in this case, this was a soccer player, I will splint them to play because they have impact type events. And then one of the final things, one of the hardest things I've found is sort of the independent digital extension. So this is sort of, as I'm getting ready to say goodbye to them, I tell them this is their final exam. I take care of a lot of students. So I say this is the final exam. And it's hard early on, they can have good composite motion, but they don't have independent digital extension. And that's something that I like to show them and demonstrate. And you can see, obviously, his scar is still hypertrophic, so we're still pretty early on in this. So thanks, Nick and Becky. So next case, Lauren Grossman, are you on the line? Nope. How about Harry?
Hey, Jeffrey.
Yep. Oh, hey, Try.
Hey, can I just review something for the audience?
Sure.
So when you're doing fixing a metacarpal fracture with just interfragmentary screws, they should fulfill, just for a recap, exactly what Nick and Jeff said. It should be a long oblique or spiral fracture. The length of the fracture should be at least twice the diameter of the fracture at the center of the fracture. The screws must follow the spiral, as Jeff alluded to. And finally, coming to the size of the screws, try to maintain at least twice the amount of size of the screw head at the point of insertion. And the last thing is, all screws should not enter from the same side if you don't need to. They can always come from opposite sides, and that's perfectly fine. So 5 criteria you should remember.
Excellent. Thanks, Try. So Harry Hoyen.
Jeff.
Hey. So this is a 30-year-old, we'll call him an athlete, but he's more of an enthusiast, sort of a drunk middle of the night fight. Right hand dominant involves his only his ring finger. It's his only injury.
Yeah, so this is the sort of the metadiaphysis, let's say, of the diaphysis. Do you have another X-ray here that we could look at, or you just got a single shot here?
I do.
There you go. Okay. I was going to ask you how much, how much angulation did he have? The malrotation could provide us with some examination. Obviously, this is closed, Jeff, I assume?
It is.
Yep. Neurovascular, okay.
Mm-hmm.
And these typically, especially the central ones, where they have a direct impact, often don't have a tremendous amount of malrotation because it's maintained by the intermetacarpal ligament. It's supported, as Nick was saying, by the central digits, but it becomes a composite, as you can see on the lateral radiograph, which is quite interesting. It becomes a composite of shortening, angulation, and the fact that the metacarpal head becomes or goes into the palm. You sort of get those 3 things.
Exactly. So clinically, he sort of has lost his knuckle there, but he's gained a new knuckle. It wasn't coincidentally that I picked out a purple arrow for that, because it is sort of tenting the skin, and that skin is not looking so healthy.
Yeah, and there's a certain amount of biomechanics have been worked out. The amount of angulation limits the total extension and flexion of the digit, and then also the amount of shortening can relate to the amount of loss of flexion and extension. So you add all those things together, and realistically, this at least needs a reduction. And oddly enough, sometimes you can, if it's not buttonholed through the interosseous fascia or around one of the extensors, you can maintain these occasionally in a cast. It depends on our patient individual. Just because the X-ray looks like that, does the individual present a increased complication profile? The last thing you want is an infection, and then you have to wash it out, and then there's other problems down the road, as certain individuals may have problems thereof. So first thing is a reduction.
Yep. So in the ER, this was the beginning, and this was the end.
Yeah, that's exactly right. Sometimes they walk in and then they walk out again.
It wouldn't move. Yep.
Yeah. So if it didn't move, then as I said before, there's something stuck, right? It could be the fascia, it could be the tendon. In that instance, this is, for me, from an operative standpoint, dorsal exposure and most likely neutralization plating. It may be difficult to lag some of those pieces in together. Pretty straightforward.
So took him to the OR and tried it under fluoro, under regional, and it really didn't move.
Yep.
So again, our incision.
It's a good point, because it'll be interesting to see what you have on the clinical photos, is that why isn't it moving? It could be periosteum. I've seen neurosci. Obviously, this is a tendon, so it's okay in this instance, but hopefully we'll gain some light for the audience here.
Yeah, so sort of going through layer by layer. So come through skin and you see the peritoneum and the extensor tendons. And then now we've got the extensor tendons retracted, and you see his periosteum is actually still intact. And as Harry sort of alluded to, that can actually be part of the problem, because remember, as Nick showed, those intermetacarpal ligaments are sort of like an X-fix rail distally, and that actually can sort of tether this segment. So upon incising the periosteum, and now you see that the fracture's really 100% displaced, meaning that the distal intramedullary canal is completely open, as you see here, and the cortices are sort of jumped, and it was actually hard to get reduced even open. It didn't just fall back into place. So much for closed reduction pinning. But then there's our reduction. And you see the AO juice, as we used to say, the nice anatomic reduction. And then in terms of plating, there's different options for you, as Harry said and as Nick said in his talk. This mostly transverse fracture doesn't really lend itself to a lag screw, so we're left with some type of plate once we've opened it, and whether that's a compression plate or a tension band plate, as Nick sort of said. So Harry, what are your thoughts?
Yeah, this is sort of, as you know, as the metacarpal has this curve to it, it's a bit of the tension side bone, and they act a little bit together. And what you allude to here is that when they reduce, and you can get them reduced, they're amazingly stable. They sort of hold as long as you have an intact on the tension side. If there's a little butterfly oblique on one of the medial or lateral borders, or the columns of that very thick cortex, it becomes a little more difficult. But when in this instance, they hold fairly well. So it's a relatively thin dorsal plate on the contralateral side. I'm sorry, on the tension side, as you are here. And if you can compress across it, fine. But you got to make sure you have a good volar and dorsal cortex to do that. And I try to get 2 screws on each side, 2 good screws on each side.
Yep, and then just so that everyone sort of has perspective, so you can see the metacarpal, you see the flare here, and I haven't taken down the capsule, but pretty soon you're getting into articular cartilage. So
I need a T-plate.
Yeah, exactly. So number one, we obviously there's not much articulation there dorsally, but remember, this bone here is really cancellous bone. It's the metaphysis. It's not the cortical bone like it is down here. So the bone really has a different characteristic within a very short distance.
And these are notorious actually for afterwards getting a little stiff, right? Because you're in that pericapsular area, right? Mm-hmm. So the plate has to glide over there. And this is kind of a neat way. So this is a great discussion. I was going to ask a couple of questions, but this is very short segment fixation, right? So it's 3 and 3, but it's a lot of stress and strain put on the fracture. So if you have short segment fixation, you have to match it with implants that can bear a lot of stress. And the I-beam, or so the broad beam construct of this plate can bear a lot of stress versus a let's say a T-plate or a straight plate that's in the reconstruction. So
and it's hard to tell from this perspective, but this plate is I call it a ladder plate, or it's a 3-dimensional plate in that it has a curve.
Yep.
So you get the benefit of the H cubed not being a 2-dimensional structure, but it's actually a 3-dimensional structure. And again, it's hard to see, but the fracture sort of runs up here, and I have it a little bit off kilter, so I can get a cluster of 3 and a cluster of 3 screws in that very short segment, as Harry noted.
My only caveat is that occasionally on the volar side, these fractures can propagate, and you can't see them. And you take your first X-ray or 2, and one of those screws is in the fracture site. Sometimes you can use that to your advantage and go, and if it's laggable, or not laggable, but interfragmentary compression to a certain extent, you can use that to your advantage. Some people have sort of popularized, and it's a little bit difficult in this open, but these intermedullary screws in these instances, especially for the border digits, because you can get the let's say the phalanx down out of the way, and you have straight shot to the metacarpal head to place a screw down the canal to avoid tendon problems later on.
Yep.
I haven't done it so often, but I have a couple of colleagues here that use it a fair amount. So I don't know if anybody.
Well, I like it, and I know we have a big enthusiast on the line in Chai, but this one, like I said, it failed step number 1 in getting a close reduction. So once it was committed to opening, then that no longer was an option.
Well, could you still use it though? Because the tendon gliding characteristics are fantastic, right? I don't know. It'll be interesting to Chai whether he's done them once you have an open.
Once you do a big open and then do an intermedullary screw, yeah. So this is a low profile plate that then you can actually close the periosteum over. So this is a few chromics in the periosteum.
So it's a 1.5 plate, Jeff?
This is a 1.7, I think.
1.7,
yeah.
Got it, yeah, okay.
So, you know, again, so restoring that gliding, because as Harry mentioned, you know, the tendons want to adhere and become adherent. So, you know, as we talked about, as Becky talked about before, getting them moving early. And then this is just what the construct looks like. And again, it's a pretty low profile plate, but it's very rigid, this sort of concept of tension band plating. And then this actually represents the last time I saw him, which was at about 3 weeks. But fortunately, I sort of anticipated that. And Harry, I picked you for this. I don't know if you can read his tat here.
There you go, Cedar, baby.
That's right.
He's from my area, right?
Exactly.
You know, my neck of the woods. And you know, go back to the other X-ray. It's really interesting the resorption that occurs on the volar side, right, early on, or the first couple of weeks, and you sort of have to trust things, because that's where, let's say, the comminution was. And because of this, because it's such a rigid construct, you're going to get a little more primary bone healing than you think, or you're going to have a lot of stress. So I'm not too alarmed, but in these situations, you get a little bit of that resorption first, and then you get some bone formation last. And you can see he's actually broken his 5th metacarpal there, hasn't he?
Yeah, and I actually did get longer term follow up on him with a Bennett's fracture. So I got like 4-year follow up on him circuitously.
That's an interesting case. But
at a few weeks, again, getting him moving, and you can see I'm sort of pointing. He's got a little bit of an extensor lag of that ring finger at that point. But you know, back to his activities.
There's a couple of questions. Go ahead, Jeff. Why don't you do those?
Yeah. So, how would you handle a head fracture? So again, as Nick said, that there's actually a talk, I believe next week, Glenn Gaston is talking about, but briefly, metacarpal head fractures. I tend to use either like a micro headless compression screw, or some people will use a more traditional lag screw and just countersink it, so the head is below the articular surface to get it anatomic. And then there's another question: any use for blade plates these days? So blade plates or a condylar plate with a locking screw fixation can be useful more on the border digits, meaning the index or the small metacarpal is a possibility, especially in a periarticular fracture. But I usually would tend to think of a condylar plate or a blade plate for something like that.
You know, it's in that neck area, and the idea was to try to, you know, sort of get it away from the tendon. You know, and they're much easier, obviously, as Jeff says, in the border digits. It's a little bit harder in the central digits, but then you don't potentially get as much tendon irritation with the blade plate.
So Chai, this one's for you. This is a 19-year-old right-hand dominant college student who punched another player during a pickup basketball game. Yeah. So again, it's sort of an athletic injury.
Athletic, yeah. So does he have any malrotation?
No malrotation.
Yeah, but the angulation is about 45 degrees, isn't it?
It is.
Yeah. So there's a couple things here. one thing is, if we accept the numbers that Nick gave, then this shaft angulation falls outside those limits. And one of the concerns we have is with angulation of apex dorsal of this degree, you run the risk of developing pseudo-clawing in the future. I mean, is this a life-threatening or a limb-threatening injury? Absolutely not. But at the very least, you should try and do a close reduction. But controlling it is going to be challenging because this is punching, so it's a relatively high energy injury. And does this person want to have any surgery?
Yeah, so he's amenable to it. The one thing that I always like to point out, if you think about those numbers and the angulation, if you think about a 45-degree angle in the subcapital area, you're just basically getting rotation of the head. Whereas when you have that same 45-degree angulation and you move it back, you know, a couple centimeters in the metacarpal shaft, you're then projecting that whole metacarpal or translating that whole MP joint palmarly. So he's a pretty slender guy, and he notes his fifth MP in his palm, and he does play tennis in addition to other things, and anticipates that that's going to be a problem. So he is interested in doing something.
Right. So I mean, that's palmar prominence of the metacarpal head is a theoretical concern, but I can honestly say that I have yet to see it becoming a concern which required addressing something in the future. That's neither here nor there. But I think this is not acceptable, the position, and I would be inclined to fix it.
Okay. What would you?
It's a shaft fracture. And when I originally described the intramedullary screw technique, 10, 12 years ago, I was using it only for subcapital fractures. But since then, I've extended my indications to utilize it for shaft fractures in high performance athletes. But if that is not possible, and I think just a simple traditional dorsal plating would be just fine.
So those were my thoughts exactly. And Chai, I did want to bring up this little chestnut that you taught us all about this, and again described for subcapital or metacarpal neck fractures. But I agree, I've expanded, and many people have expanded the indications for it. The one other thing, and Nick pointed this out, Chai did a follow-up study, and basically if you think about where the proximal phalanx actually articulates and weight bears on the metacarpal head, it's sort of in this area, and sort of the sweet spot for the screw is in this dorsal third. And then there's this very, very nice sort of a 3D CT based picture that again really shows you can imagine that proximal phalanx articulating here, and the hole, which, as Nick said, fills in with fibrocartilage, but the defect is really well tolerated, because if you think about it, you have to load your MP joints in hyperextension to actually articulate with that. So it is articular cartilage, but it's not articulating in most instances. So again, as Chai said, that's an option, and that's exactly what I did. So Chai, comments?
Yeah, I mean, that's the way it's supposed to be. The beauty of it is that you want to make sure that you template. And like Nick pointed out, the fourth metacarpal is gracile, and you can get a 3 millimeter screw in all the other metacarpals, but in the fourth metacarpal, you have to be able to think about going smaller, like a 2.4 millimeter screw. The entry points in the dorsal third, and may have caused a little bit of angulation there, but it's difficult to say with this view. But it doesn't matter if it gets him back to play early. This is one technique with which I feel relatively safe letting them get back to play early. And the rehab is very simple.
Hey, Jeff.
Hey, Tom.
Hey, sorry I'm late tonight, gentlemen.
It's okay.
One thing, I don't know if you mentioned it, but a shaft fracture in the small finger, we consider rotationally unstable as well. So from my perspective, when you start to think about the ideal treatment for that injury, I think you have to think not only of fracture stability, but rotational stability too. So for me, this wouldn't be my choice. I probably played it personally, but certainly you can get away with it as shown here. So just one other thing to consider potentially.
Yeah, absolutely. He did not have malrotation on presentation, but if that was something that I was trying to control, then a plate does that much better, as you noted. The one thing I will say, and Chai sort of alluded to this, is you sort of have to know what implants are available to you, and not being specific about brands or anything, but these different screws come in different lengths. And now many of us are using software on the imaging that allows you to get an accurate measurement. And the difference between 35 millimeters and 40 millimeters is important, because some of the companies, their screws stop at 35 and some go to 40 and some go to 50. So you want to make sure that you have a device that allows you, in this case, to get the threads completely across the fracture and not ending at the fracture.
Just one other comment too. I've actually seen this break at the fracture site with a delayed union in an athlete. So that's the other thing to consider.
Well, it's funny that you brought that up, Tom, because I believe that was one of the questions. How would you deal with it? So how did you deal with it?
Fortunately, it wasn't my case because I wouldn't use that screw on this fracture. But that was dealt with by that person with a kind of a short plate, honestly. I think it was a 4 or 5 hole plate, and the screw was removed.
Yeah. Yeah. So, I mean, if you did, so the question was, if you had a non-union in one of these, removing it, obviously, if it breaks, you're going to mobilize the fracture enough to be able to debride it, potentially bone graft it. So you could get the broken part out literally through the fracture as you flex and sort of open book the fracture. Take advantage of the fact that it remains cannulated.
Yep.
Yeah, better that it's not your screw.
Jeffrey, we looked at complication rates after intermedullary screw fixation, and I think we had a total N of 150 or 155 cases, and a complication rate was under 4%, which is comparable to everything. And that included one bent screw, broken screw, I think, one nickel allergy, and something else. But the bent screw was asymptomatic in a wall puncher second time around, and that was my patient. So I have gone away from using this technique in wall punchers, because the one thing I've learned over the years is if people punch a wall once, they're likely to punch a wall a second time. So.
Well, this was more of a face puncher than a wall puncher, but noted.
Yeah.
So Nick did show a little of this in his talk, but for those of you not familiar with it, basically you in my way, and I'll invite Chai to give us the real way to do it, but basically you want to make sure you can get a close reduction. So bring in fluoro, confirm that you can get a close reduction, and then remember we're in the the dorsal third of the metacarpal head. Put your guide wire down. And often, just the guide wire makes the fracture line up, and it sort of serves as that intermedullary nail. And then a small incision that I usually close with a stitch or two, longitudinal incision in the extensor mechanism. I'll show you some clinical pics of him where you might be able to see his incision. And then, but you basically can get him moving very quickly. As Becky had mentioned before, and it's hard to see, but his incision is sort of right there. So here he is at 5 weeks, still has a little bit of an extensor lag at his PIP joint, as you see there. And then, as I sort of mentioned before, the sort of the final or the hardest thing to do, and you can see he's got that independent small finger extension, but still a little bit of an extensor lag at the PIP joint. So Chai, other than not doing this in wall punchers, are there any other patients that talk you out of it, or fractures that talk you out of it?
No, I mean, I have expanded the indications also to trans hand metacarpal amputations. So if you have a revasc or a replant of a hand at the metacarpal level, This technique allows you to get the bony fixation done really, really fast and get to the micro part of the case. So I've started using that because plating those fractures can be enormously time consuming, and pinning them doesn't allow you to rehab them fast. So I've gone to using this technique in those transmetacarpal amputations. And it seems to work remarkably well.
Hey, Jeff, can I ask a question? I don't know if you've covered it already, but have you talked about the different screws, compression versus static screws, and when to use which one?
Well, we didn't. So even though that most of what's available out there are called headless compression screws, this is really sort of a more of a static function, meaning it goes in, but you're not really looking to get compression.
Well, so one of the most popular screws out there, I forgot the name, to be honest with you, is not a compression screw. And I wasn't aware of that, frankly, when I put it in. I assumed it was a cannulated compression screw. And if you're not careful, those screws can distract. So it's just something to be aware of. It's just the screws do vary, and it's important to understand which do what.
Yeah.
Yeah, that's a good point that Tom raises. When I described this operation, this was meant to be really an internal splint with a minimally invasive procedure to allow early rehab. And that's why I emphasize the importance of templating and getting isthmic perches with the leading threads. And if the isthmus is too narrow, then maybe you want to go to another procedure. Because if the threads get bound up in the isthmus, exactly what Tom said will happen. It will distract the fracture.
Yeah, absolutely. And then you have to remember as it's working real hard to get through that isthmus, you're in that cancellous bone distally. So whatever fixation you have on the head, you're losing as that screw is just spinning and not advancing because it can't move through the isthmus. So as Chai said, preoperative planning is important.
Do you guys go through the extensor directly, or try to go through the sagittal band, or really doesn't make any difference?
I make a little longitudinal nick in the extensor.
Yep.
Chai?
Yeah, exactly. I have even, depending on the fracture location and everything, I might even do a local capsulectomy if I make the incision, say, about 1.5 centimeters to avoid the chance of any binding up of the capsule to the extensor mechanism. And it's easy to repair with buried non-absorbable sutures. The extensor, that is.
Mm-hmm. So there's a couple questions. One from a lot earlier about bone grafting and open metacarpal fractures, and I think it was brought up about during Nick's talk. In other words, would you bone graft acutely versus do you do it in a stage procedure, Nick?
Yeah, I think there was just a systematic review about that came out last year from Chuck Day, and I think he thought that there was really no risk of acute bone grafting in open metacarpal fractures. That's sort of what they found. But of course, it depends on how dirty your open fracture is and other sort of considerations.
Yeah, and then sort of a follow-up question, and I agree, and I think that's what the literature shows, that with an adequate debridement, you can do definitive management, including bone grafting for defects. And that relates to another question about segmental bone loss in metacarpal, and obviously, that requires a plate that allows you to get enough fixation proximally and distally, respecting the CMC joint and the MP joint. Making sure you get rigid fixation, and then being able to bone graft that. And then there's a question about my PIP extensor lag. Becky, what I know what I do, but I don't know that it's the right answer. What do you do for PIP extensor lags?
Yeah, I was just trying to type a quick answer to this. So I think it's incredibly important. And I think Dr. Poulos did a really nice job of thinking about the anatomy in the beginning and all the different tendons that are providing differential forces. So I definitely want to think about MP extension as a primary action of the extensor digitorum. But I want to remember that PIP and DIP extension are given as much emphasis by using the lumbricals and interossei. So really trying to create extension of the PIP and DIP with the MP and flexion will help to really push some of that force from the EDC through the mechanism to get full extension of the PIP and DIP. So I think remembering that composite extension is a function of both intrinsic and extrinsics, and trying to isolate those early in the rehab process will help make sure that you're going to get good glide of all the different tendons working in concert with one another.
And are you making patients a blocking splint to do that, or are you just having them do it on their own with their own opposite hand? How do you find that it works the best?
Yeah, I think it's great to observe. And so the one thing is I want to educate the patient that if they're getting really a lot of MP hyperextension, then I'm going to create some blocking for them. But if they can do a pretty good job of keeping things neutral, so extension without too much hyperextension and good flexion, I think that's great. But also teaching them really to create the intrinsic plus position during exercise, I think is important. So even going from a fist just to kind of intrinsic plus position is a really helpful way for them to glide forces through the mechanism.
Hey, Jeffrey.
Chai?
You know, there's a question about the segmental bone loss. And I think about grafting primary or secondary, it's always good to parse those wounds into badly contaminated and not so badly contaminated wounds. So I don't think you need to do anything primarily in terms of grafting it if it's badly contaminated. But one thing I've used quite a lot in the past is the masquelade technique, where you take bone cement and you make a rolling pin out of it, for those of you who might be active in the kitchen. And the two ends of the rolling pin go into the medullary canals, and the rest of it stays in the middle. And you can leave that in forever, allows you to get a nice envelope around that cement, and you come back later and graft it and fix it. So it's a good thing to remember.
Yep, it's something that we do in the forearm and the humerus and the long bones, and it works in the smaller long bones too.
Absolutely, absolutely.
All right. So another question about a comminuted intra-articular head of the metacarpal, difficult to reconstruct primarily. So again, if you know, the talk, I would invite you to tune in next week for Glenn Gaston's talk, where we're going to talk more about metacarpal head and articular fractures. But again, it's a matter of piecing it together, getting the articular surface reduced. If you can do that, ideally with some type of buried screws, either a headless compression screw or a buried lag screw, that's great. And then you can think about early motion. If the fragments are too small and they preclude getting rigid fixation with screws, I have in that situation pieced things together with K-wires and then gone back, you know, realizing that that wasn't rigid fixation and the K-wires really get in the way of motion, and then gone back and having done a planned, you know, bone graft at some point, and then even a capsulectomy. But obviously you have one chance to get the articular surface anatomic. So thank you. Let's see, I'm just looking. I think that we've addressed all the questions. So thank you to Nick. It was an excellent job. So again, please stay tuned. There was a number of questions that sort of overlapped this talk and next week's talk, which is going to be on articular fractures. And again, remember, this is part of a series that goes through mid-November. After 24 hours, this talk and all the talks are available on the YouTube AO Hand channel, so you can get access to anything that you missed. And again, thanks everyone. And Nick, great job. Excellent. Thanks.